Jorge Florez. I'm a graduate medical student from Universidad de los Andes in Bogota, Colombia. And today I will be talking about Moyamoya. These are the topics we are going to discuss: the definition, pathophysiology, epidemiology, clinical presentation, diagnosis, treatment, and prognosis of this condition. So, Moyamoya, it's a chronic progressive stenosis of the terminal portion of the proximal branches of the internal carotid artery. This stenosis will progressively cause an ischemic changes in the anterior cerebral perfusion, and aiming to compensate this reduced blood flow, some collateral vascular network will be produced in these locations. So this condition was first described in Japan by Takeuchi and Shimizu in 1957. It was described as an hypoplasia of bilateral internal carotid arteries. Later on, in 1969, Suzuki and Takaku gave the name of Moyamoya, which is a Japanese expression that means a puff of cigarette smoke. They gave this term because the radiologic pattern that we can see secondary to the collateral vessels, it's similar to a puff of cigarette, as you can see in these images in the left. They are very similar. Now, to speak about Moyamoya, we need to define three key concepts. The first one is that Moyamoya alone only refers to the distinctive or characteristic findings of this condition in an arteriography. If you have this pattern in a patient and it is primary or idiopathic and it is associated with a genetic predisposition, it is considered Moyamoya disease. But if this condition is associated to another condition, such as Down syndrome, sickle cell disease, neurofibromatosis type 1, or previous cranial radiation, it is considered Moyamoya syndrome. Traditionally, it was defined as a bilateral compromise of the internal carotid arteries. However, nowadays, we know that even a unilateral compromise is also considered Moyamoya. In fact, 40% of patients with unilateral compromise will lately develop contralateral compromise. Now, regarding the pathophysiology, first we should talk about the genetic aspects of this condition. It is considered a polygenic condition, as there's a lot of mutations that has been associated to it. In some studies about the inheritance of this condition, certain mutations have an autosomal dominant inheritance characteristic, but it has an incomplete penetrance. The most frequent one is the RNF213 mutation, which is present in chromosome 17. It is the most frequent one in East Asian population, and it's been observed that it has a low familiar penetrance of only 23%. And this low penetrance has been associated to the some epigenetic modifications that might be required in order for the condition to start to develop. Regarding the pathophysiology, there's still a lot of gaps in the understanding of the whole process. However, it has been observed that an overexpression of angiogenic factors are associated to the development of this condition. Some of the most important angiogenic factors are the basic fibroblast growth factor, the transformating growth factor beta 1, hepatocyte growth factor, and vascular endothelial growth factor. This overexpression caused an disorganized and aberrant endothelial proliferation, as well as smooth muscle cells proliferation. This disorganized proliferation will eventually cause an intimal thickening and occlusion of these blood vessels. And as a consequence of the reduced blood flow and the reduced oxygenation of the brain tissue, this will produce a neovascularization process that will cause the production of new collateral vessels that unfortunately are aberrant, as they have fragile walls and they could also have microaneurysms. These last two characteristics are the ones that make a greater risk of bleeding episodes in these patients. Regarding the epidemiology, this condition is more frequent in Eastern Asia populations, especially in Japan, China, and Korea. For example, in Japan, the estimated incidence is between 0.35 and 0.94 cases per 100,000 people. And it is the most common cerebrovascular disease in children in this population. In the United States, one of the most recent studies have estimated the incidence in 0.57 cases per 100,000 people. And it has been observed that Asian Americans and African Americans have more frequency compared to white or Caucasian population. This condition could happen at any age, but it is more frequent in children during the first decade, especially around the age of 5, and also in adults during the 5th decade of life. And finally, this condition is more frequent in women than men. Considering the definitions we gave at the beginning about the Moyamoya disease, Moyamoya syndrome, Moyamoya disease, or the idiopathic form of it, is the most frequent one. It is the 50 to 75% of cases. And 10 to 20% of cases are from Moyamoya syndrome or due to an associated condition. Clinical presentation of this disease could be ischemic manifestations or hemorrhagic manifestations, being the ischemic ones the more frequent. If we compare children and adult populations, adult patients, adults tend to have more hemorrhagic episodes than children. The ischemic presentation that could occur are complete strokes or transient ischemic attacks that could happen frequently in these patients. Another manifestations are seizures, syncopes, and visual deficits. In children, this condition or these stroke episodes could be triggered by some events that could cause reduced blood flow or vasoconstriction, such as hyperventilation, exertion, and dehydration. That's why in children, it is more difficult to identify transient ischemic attacks, and it's more frequent to identify them with complete strokes. Regarding the hemorrhagic manifestations, they are a consequence of the rupture of fragile collateral vessels or rupture aneurysms that could cause hemorrhages in intraventricular zones or intraparenchymal or subarachnoid hemorrhages. Other important manifestations include headaches, which are migraine type headaches that do not respond to medical treatment. And they are caused due to the dilated collateral vessels that will stimulate dural nociceptors. Other presentations are choreiform movements when there is a compromise of basal ganglia. And finally, there is a very interesting association with the morning glory disc anomaly, which is a congenital anomaly of the optic nerve, in which there is a funnel-shaped excavation of the posterior globe that will also affect the optic disc. As you can see in the right, this image resembles the one of a morning glory flower, and that's why they give this name to it. So when you should suspect this condition? You should suspect it in patients who are presenting repeated ischemic attacks secondary to low perfusion, and they tend to be in the same arterial territories due to the obstructions that are happening. Also, you should suspect when they occur with repeated hemorrhagic events without common risk factors in regions that are supplied by the small vessels derived from the circle of Willis. And also, if you have associated conditions that we mentioned before, such as Down syndrome, neurofibromatosis type 1, or previous cranial radiotherapy. If you have any of these suspicion, you should make a neuroimaging, such as MRI, MR angiography, to try to identify the presence of this radiologic pattern. As I was saying before, MRI is one of the initial imagings that we can make to identify this condition. Using this test, we can identify chronic ischemic changes or past hemorrhagic events. Also, there is some signals or some signs that are characteristics, such as the presence of void signals in the T1 or T2 sequences, that they are happening due to the presence of dilated collateral vessels. And one of the most sensitive signs is the IV sign, which you can see in the flare sequence. As you can see, they are similar to IV plants, but they seem to be in the brain, and they are due to the engorgement of leptomeningeal vessels. It has been said that 80% of patients with Moyamoya have this sign present. A more sensitive exam would be the MR angiography that could help to locate the occlusion of the stenosis of the internal carotid artery and the presence of the collateral vessels. Also, CT angiograms can be used to identify this condition. However, the gold standard for the diagnosis is the digital subtraction angiography. Here we can see a normal angiography from the internal carotid artery. You can see how beautiful it looks. When there is the presence of Moyamoya, you can see that there's a narrowing of the internal carotid artery. This is like an early stage. In subsequent stages, you can see the appearance of the puff sign that corresponds to the presence of the collateral vessels. And this last image is from a severe occlusion or a late stage Moyamoya, in which the occlusion is so severe that the puff sign is lost in this exam. So in order to define the severity of the condition, the Suzuki grading system is used. Being grade 1 and mild narrowing, and grade 6, a total occlusion of the internal carotid artery and the disappearance of the collaterals. Regarding the treatment, there is no treatment able to revert or cure this condition. So they are focused on improving cerebral perfusion and reduce the odds of presenting new stroke events. And also, if you have an underlying condition that is associated to Moyamoya, like sickle cell disease, if you have an adequate treatment of it, you can reduce the frequency of new stroke events. Regarding the management, if we talk about the acute management, it is similar to the way you will approach any patient with stroke. However, especially in children, you should avoid any kind of conditions that will cause a reduced perfusion or vasospasm, as it may trigger additional stroke episodes. For that, you should give an adequate supplemental oxygens, avoid hypotension, avoid hyperthermia, avoid hypocarbia, have an adequate pain control, and you should give more maintenance isotonic fluids that are 1.25 to 1.5 times the normal rates that are given. Regarding medical treatment, it is used as a secondary intervention to prevent new episodes. They are indicated when there are high risks with the surgery or contraindications for the surgery, and also in cases of mild disease. The most frequent medical treatments that are used are anti-aggregating therapies, such as aspirin, clopidogrel, and cilostazol. This last one is the most frequently used in late years, as it has a very good safety profile, and it has been very effective in reducing the events of stroke in these patients. As you can see in the figure in the right, the use of cilostazol have increased dramatically in the late years due to these benefits that they have. Regarding surgical options, there are two approaches, one direct revascularization and one indirect one. The direct revascularization, it is the stroke bypass surgery between external carotid arteries vessels and an internal cerebral vessel in order to improve the cerebral perfusion. This approach is preferred in adult patients than in children, because children, as they have more fragile vessels, there's a higher risk of complications in them. Here in the right, you can see an example of a bypass between the parietal superficial temporal artery and the angular branch of the middle cerebral artery. The second approach, that is the indirect revascularization, it tries to promote the development of a new vascular network in the region that is affected by the condition. This is the approach preferred in children, and it consists in implanting a vessel in this region and leaving it to produce new vascular supply in it. For example, in this case, you can see that the same superficial temporal artery, it's been inserted in the cerebral parenchyma in order to induce the production of new blood vessels. Regarding the prognosis of this condition, it is progressive, and what it could change is the rate in which it will happen. It could be slow, intermittent, or it could have a fulminant progression. And with every episode of stroke that happens, some cognitive and neurologic decline will be occurring in patients. That's why the best long-term predictor for these patients is their neurological status in the time the treatment is going to begin. Finally, I would like to share with you some recent studies that has been published, and this one was really interesting. They are trying to find some non-invasive biomarkers that could help in the diagnosis or the follow-up of these patients. In this case, in this article from Frontiers in Neurology that was published in this month, they were trying to measure the levels of 4 biomarkers: matrix metalloproteinase 9, matrix metalloproteinase 2, and vascular endothelial growth factor. And they saw that the levels of these biomarkers were significantly high in patients with Moyamoya compared to control. And they also saw that it could work as a progression marker, as a follow-up marker. They measured the levels before surgery and after surgery, and they saw that the levels of these biomarkers were reduced after a successful surgical intervention. So this will open new possibilities in the follow-up of these patients. Thank you so much for your attention, and I will be happy to answer any questions you have.